Hello, everyone, and welcome to our module on lung cancer. Shown on this slide are the four most common types of cancer in the United States. Breast cancer is the most common cancer among women. Prostate cancer is the most common cancer among men. Lung cancer is less common than breast or prostate cancer, but it is more deadly. It is famous for being the most deadly form of cancer. And then finally, colorectal is the third of the four common types of cancer. One of the major risk factors for lung cancer is cigarette smoking. As we'll talk about later in this video, cigarette smoking is associated with squamous cell cancer of the lung and also small cell cancers of the lung. Cigarettes contain substances called polycyclic aromatic hydrocarbons, or PAHs. These are a type of hazardous molecule found inside of cigarette smoke, and that's what is believed to drive the formation of cancer of the lung. Radiation therapy is also a risk factor for lung cancer, so patients who have Hodgkin's lymphoma or breast cancer often require chest radiation, and when that happens, years later they can develop lung cancer. And then finally, there are a number of environmental toxins associated with lung cancer. I talk about these in other videos, but these are things like asbestos among certain industrial workers and also radon. Let's talk about some of the symptoms of all types of lung cancer. So the first thing to know is that unfortunately, lung cancers are usually advanced at the time of presentation. This is one of the reasons that lung cancer is the most deadly form of cancer, because by the time it causes symptoms and gets detected, it's often already spread widely. Some of the symptoms you can see are things that are fairly obvious if you think about what a tumor in a lung might cause. So patients can develop cough, sometimes they can have dyspnea, there can be bleeding into the lungs. This can lead to hemoptysis. And then if the tumor obstructs the bronchioles, then you can sometimes get wheezing as well. And so these types of sort of non-specific symptoms of lung disease often lead to chest imaging, either an X-ray or a CT scan, and that's usually how the diagnosis of lung cancer is initially made. Another way that lung cancer is often identified is by finding a pulmonary nodule when you do chest imaging for any reason. So if you look at this slide here, circled in red is a small circular lesion in the right upper lobe. This is sometimes called a pulmonary nodule or a coin lesion, and this is a common finding when chest x-rays are done. These lesions are very small, they usually don't cause symptoms, but once they're identified, the worrisome thing is that they could represent cancer, although there are other benign causes. When you see one of these on x-ray, it's usually followed up by a CT scan, which usually shows a non-calcified nodule. That's the finding of a nodule that you're worried about that could be cancer. One of the first things you always do when you find one of these lesions on chest x-ray or CT scan is compare with prior imaging. Many patients have had imaging over years, and if you see this lesion and it's been stable for many, many years, it's less likely to be a cancer. And ultimately, what you have to do is do a biopsy to get a diagnosis. And later in this video, we're going to talk about all the different biopsy findings and which type of cancer they indicate. You should be familiar with a couple of the causes of benign pulmonary nodules. These are often identified on chest imaging, and the worry is that they could represent cancer, but some of the benign causes are what are shown on this slide. So first of all, granulomas can lead to formation of a nodule. About 80% of benign lung nodules are granulomas. Usually this occurs in a patient who had a prior fungal or tuberculosis exposure. And sometimes these exposures are asymptomatic or very mildly symptomatic, so the patient isn't aware that they were ever exposed until they have chest imaging and it finds one of these granulomas, and concern is raised that it could represent a cancer. Another cause of a benign pulmonary nodule is a hamartoma. So a hamartoma is a mass that contains tissue from different organ systems all sort of stuck together. In the case of lung hamartomas, these usually contain lung tissue and also cartilage. They can have scattered calcification as well. And so on this slide is a picture of a granuloma over here. This is in a CAT scan. And we've got a picture of a hamartoma over here in another CAT scan. You won't be expected to make a diagnosis of one of these things from imaging. That's a very advanced skill, but you just should be familiar with what they look like. Basically, they're small masses in the lungs, and the concern is that they could represent lung cancer. Okay, so now let's talk about different types of lung cancers. And broadly, we split lung cancers into two types. The first type is small cell lung cancers, and the second type is non-small cell lung cancers. Small cell lung cancers have a very poor prognosis. These are fast-growing tumors. They metastasize early. They are usually not amenable to surgical resection because they've already spread so widely at the time of diagnosis. They're strongly associated with smoking. The treatment is mostly with chemotherapy, and as I just mentioned, overall, small cell lung cancer has a poor prognosis. Luckily, this is only about 15% of lung cancers. More commonly, patients develop non-small cell lung cancers. This represents about 85% of lung tumors. These tumors can sometimes be resected and completely removed through surgery. In general, they have a better prognosis than small cell cancers. And these can occur among smokers, but there are certain subtypes, and we'll talk about these in this video, that are more common among non-smokers. So you can see these non-small cell tumors in smokers and non-smokers. Let's talk about small cell cancer in a little bit more detail. So small cell cancers are tumors that are made up of poorly differentiated small cells. That's how they get their name. This is a picture of a biopsy specimen from a patient with small cell lung cancer on the slide here. You can see all these small purple cells. Some of them are rounded, some of them have funny shapes, but this is what small cell lung cancer looks like under the microscope. I mentioned this earlier, but this is a very aggressive tumor. It's often spread widely at the time of diagnosis. It's a classic tumor to occur in smokers, and it's more common among males. It's also a neuroendocrine tumor, so we'll talk about this in just a minute, but in some cases, small cell lung cancers produce hormones that can affect other systems in the body. Usually these tumors arise centrally, so if you think about the trachea coming down and branching and going to the right and left lungs, it's often in this sort of central area where these tumors arise. And then as I just mentioned, because these are neuroendocrine tumors, they can cause paraneoplastic syndromes by releasing hormones and other substances, and we'll talk about that in just a second. Small cell lung cancers are believed to arise from cells in the lungs called Kolchitsky cells. These are specialized epithelial cells found in the lungs, and they are believed to transform into small cell lung cancers. There are a number of stains that are positive when you analyze biopsy specimens of small cell lung cancer. I've listed 3 of them here. One is chromogranin A, another is neuron-specific enolase, another is synaptophynin. I think it's pretty low yield to memorize all of these, but I state them for you now so you've at least heard them once. And all of these are stains that are positive in tumors of neuroendocrine origin, and that's why they're positive in small cell lung cancers. Okay, so as I mentioned earlier, small cell lung cancers, because they are neuroendocrine tumors, sometimes produce hormones, and this can lead to paraneoplastic syndromes. So some small cell lung cancers produce ACTH, which, as you may know, is a hormone that stimulates the adrenal glands to produce cortisol. So this can potentially lead to the development of Cushing syndrome, which I talk about in other videos. But patients with Cushing syndrome have a number of classic features. Some of them are progressive obesity and hyperglycemia. And you can watch the video on Cushing syndrome in the endocrine section to understand all the clinical features of this disorder. Some small cell lung cancers also produce antidiuretic hormone. This can lead to SIADH, which is the syndrome of inappropriate ADH release. Basically, what this will do is cause the body to retain water, and this will lead to the development of hyponatremia, which can sometimes lead to the development of confusion. So in a patient who's a smoker who presents with hyponatremia and confusion and has cough and other symptoms of lung cancer, you should think that this could be a small cell cancer producing ADH. And then the Lambert-Eaton syndrome is a neuromuscular junction syndrome that I talk about in other videos, but I'll briefly review it here. So if you look at this cartoon of the neuromuscular junction, the way these junctions work is calcium enters the neuron, and that triggers the release of acetylcholine, and in turn, acetylcholine tells the skeletal muscle fibers to contract. In the Lambert-Eaton syndrome, there are antibodies against presynaptic calcium channels in neurons. So basically, antibodies are produced by small cell cancer cells, and they block calcium entry through these calcium channels. As a result, acetylcholine doesn't get released, and you get less skeletal muscle contraction. And so the main symptom here is going to be weakness. And so in a patient who has small cell lung cancer who develops weakness, you should think of the Lambert-Eaton syndrome. Okay, so that's small cell lung cancer, common among male smokers and famous for causing multiple paraneoplastic syndromes. Now let's talk about the non-small cell lung cancers. There are a number of these. I've listed 5 of them here, and we'll go through all of these in the next couple of slides. So squamous cell carcinoma is another form of lung cancer that's common among male smokers. It's strongly associated with smoking. It usually presents as a hilar mass arising from the bronchus. So remember, you have the trachea dividing into the 2 main stem bronchi. The hilar area is this region around here, and so this is where the mass can develop in squamous cell carcinoma. The key pathology that identifies squamous cell carcinoma is the presence of keratin pearls in biopsy specimens. So these tumors can produce keratin, and that can lead to the development of keratin pearls. And this is a picture of one on the slide here. Another key finding is the presence of intracellular desmosomes. Desmosomes are connections between cancer cells, and so you can see these little so-called intracellular bridges between cancer cells and squamous cell carcinoma. This is a less easy finding to identify. You can look this up online. I think the more important finding to be able to recognize is the keratin pearl, which is fairly straightforward to identify. There is one hormone these tumors sometimes produce. It's called parathyroid hormone-related protein. It has a function in the body similar to parathyroid hormone, so it raises serum calcium. So this can lead to the development of hypercalcemia, which I talk about in the endocrine section. The symptoms of hypercalcemia, when it's severe and long-standing, are things like kidney stones, bone pain, abdominal pain, which is groans, and psychiatric overtones, which means confusion. In actual practice, I've seen a few patients who have this condition and have very high serum calcium. The main symptom is confusion from the very high calcium. You can also sometimes see bone and abdominal pain. Okay, moving on, let's talk about adenocarcinoma of the lungs. So this tumor has the name adeno in it because it's a glandular tumor, and it stains positive for mucin because the cancer cells can produce mucin much like a gland would. This is the most common lung cancer in non-smokers and in women who are non-smokers, and this is a super high yield thing to remember. These tumors are fairly easy to recognize in board questions because it will usually be someone who does not smoke, and it will also be a woman, whereas many other types of lung cancer are more common among men. Another way to recognize this tumor in a board question is that these are usually peripheral tumors, so they develop away from the mediastinum. So remember, if you've got the trachea and the two bronchi, we've talked about a lot of central sort of tumors or hilar tumors. These tumors can develop out here in the periphery of the lungs. They're associated with digital clubbing, so this can be another clue in a board question. Digital clubbing is a curvature of the fingernails that's abnormal. I talk about it in other videos. And in a minute, we'll talk about the bronchoalveolar subtype of adenocarcinoma. This is a subtype of this tumor where the chest X-ray shows hazy infiltrates. I'll show you a picture of this in just a second. It can look much like pneumonia, and it's often mistaken for pneumonia. And this subtype has a better prognosis than adenocarcinoma does overall. So adenocarcinomas have some interesting genetics. They're associated with so-called growth-activating mutations, and these mutations are found at much higher rates in adenocarcinoma than they are found in smoking-related cancers like small cell lung cancer that we talked about earlier. There's been a lot of basic science literature about these types of growth-activating gene mutations, so you should have heard this before your board exams because this may come up. Some of the gene mutations that have been described are listed here. These include KRAS, EGFR, and ALK. And then finally, this is a biopsy specimen of an adenocarcinoma shown here. Basically, the thing you want to recognize is the formation of glands. You can see these structures forming within the cancer. That's the formation of glands. They will stain positive for mucin. Okay, so I mentioned this earlier, but bronchoalveolar carcinoma is a subtype of adenocarcinoma. It's described as a lapidic subtype, and the word lapidic means scaly, and it gets this name because it grows along the alveolar walls like scale along the walls. In fact, some forms of this cancer don't invade the lungs. They are carcinoma in situ, basically growing along the walls of the alveoli but not invading tissue. I said this earlier, but this type of lung cancer can look like pneumonia on chest X-ray. For example, this right here is a chest X-ray from a patient who has bronchoalveolar carcinoma. All this white material here is cancer cells growing along the alveolar walls. Those cancer cells are also filling the left lung over here. And when this type of chest X-ray comes back from someone who has cough, you can often mistake it for pneumonia. And in fact, many of these patients have often been treated for pneumonia prior to the time when they finally have a biopsy, and it's determined that they have lung cancer. This has many similar features to adenocarcinoma that we talked about earlier. It often occurs in non-smokers. It's often a peripheral tumor. It can look like this, where it's sort of filling the lungs, but it can also develop initially out in the periphery. And one good thing about this subtype of adenocarcinoma is that it carries, in general, an excellent prognosis. And part of this is because of the pathology. Because it grows along the walls and doesn't always invade tissue, it usually isn't as widespread at the time of diagnosis. There are two subtypes of bronchoalveolar carcinoma. I think it's fairly low yield to memorize these subtypes, but I'm mentioning them to you now just so you've heard of them. The mucinous subtype is derived from goblet cells, and the non-mucinous subtype is derived from either club cells or type 2 pneumocytes. And the key pathologic feature of these tumors under the microscope is thickened alveolar walls. Remember what I said, these tumors grow along the alveolar walls, and sometimes they don't even invade. So if you look at these two images on the slide here, the alveoli normally have very, very thin walls. But if you look over here at this image on the right, you can see these thick walls with extra cells. That's bronchoalveolar carcinoma. Also, if you look at this image on the left side of the screen, look how thick these walls of the alveoli are. The alveolar wall should be very thin to allow for gas exchange. These thick type of walls shown here is abnormal, and that's what bronchoalveolar carcinoma looks like. Okay, next let's talk about large cell carcinoma of the lung. This is a relatively rare form of lung cancer. There isn't a lot that you need to know about it. Some of the important things related to this cancer are shown on this slide. First of all, it's famous for being poorly differentiated. The cancer cells are highly anaplastic, meaning they lack distinguishing features. So in particular, they don't have evidence of glandular or squamous cell differentiation. And then also, you don't have evidence of the small cells we saw earlier. This is a picture of what it looks like on the slide here. This is not very easy to recognize without some context, but you can see these large nuclei here, like this one I'm circling right here. These cells tend to be large with very large nuclei and not a lot of cytoplasm. This type of cancer is associated with smoking, and sometimes these cancers produce HCG, which is human chorionic gonadotropin. It's a hormone that normally comes from the placenta in women, but when this is produced by this tumor, it can cause gynecomastia, especially among men. It can occur centrally or peripherally, and overall it has a relatively poor prognosis, but like I said, this is a pretty rare form of lung cancer. And then the last type of lung cancer we'll talk about is carcinoid tumors. These types of tumors more commonly occur in the GI tract, and I talk about them in some of the videos in the GI section, but these tumors can also occur in the lungs, so we'll briefly discuss them here. So carcinoid tumors are neuroendocrine tumors. They're called carcinoid because when they were first described, they tended to be less deadly than carcinomas. And so if you remember that, it's an easy way to remember that carcinoid tumors usually have an excellent prognosis, and that's true of carcinoid tumors in the lungs. The cells tend to be well differentiated. These tumors do occur in non-smokers, and metastases is rare, which is another reason why they overall carry an excellent prognosis. These tumors stain positive for chromogranin A. This is a serum marker that can be used to identify lots of neuroendocrine tumors, including carcinoid tumors. And then very rarely they can cause the carcinoid syndrome. This more commonly happens with gastrointestinal carcinoid tumors, and I talk about this in the GI section. But when carcinoid tumors produce serotonin, this can cause the patient to develop flushing and diarrhea. These symptoms are related to the serotonin causing effects in mast cells. Sometimes this can even lead to wheezing if mast cells degranulate and cause an allergic reaction in the lungs. And so this is the carcinoid tumor. It's relatively uncommon in lung carcinoids. It's more common in GI carcinoids. Okay, let's talk about some of the complications of lung cancers. Many of these tie in with anatomy, so they're high yield to understand for your step 1 exam. So first of all, any lung cancer can potentially cause a pleural effusion. So when a patient presents with a pleural effusion of unknown etiology, what you do is obtain a sample of the pleural fluid. You tap the lung to obtain a fluid sample. This is called a thoracentesis. And then you send that fluid sample to the lab for cytology. Cytology involves analyzing the sample for the presence of cells, and malignant lung cancer cells can sometimes be seen, and that tells you that the pleural effusion is being caused by an underlying lung cancer. The phrenic nerve runs through the thorax, so it can become compressed by a lung cancer. When this happens, the diaphragm will become paralyzed. This can lead to symptoms of dyspnea because you need to contract your diaphragm in order to breathe normally. In addition, if you do a chest X-ray, you will see half of the diaphragm that is elevated or raised up, and this is because the phrenic nerve has become compromised on that side. And there's a test to diagnose phrenic nerve problems. It's called a sniff test. Basically, the patient is put under fluoroscopy, and you take an image as they sniff in a breath of air. And if the phrenic nerve on one half of the body is compromised, that diaphragm portion on that half of the body will not move during the sniff test. You can also have a lung cancer affect the recurrent laryngeal nerve, which runs through the chest. This nerve innervates muscles of the larynx, so when it becomes compromised, you can develop hoarseness. And this cartoon over here is just to sort of remind you of some of the relevant anatomy. So the top portion of the lungs is near the aortic arch and the pulmonary artery. And so up here you can find nerves like the recurrent laryngeal nerve and the phrenic nerve. And these are the type of things that can become affected by a large lung tumor. Another potential complication of lung cancer is development of Horner syndrome, which is a neurologic condition that I talk about in many of the videos in the neurology section. Horner syndrome occurs anytime there's disruption of the sympathetic nerves that supply the face. So sympathetic innervation to the face starts in the brain, it goes down into the chest, and then the nerve fibers come up to innervate the face. So if you have a lung cancer, especially a lung cancer towards the top of the lungs, it can potentially disrupt this nervous system, and then you won't have sympathetic innervation to the face, and that's what causes Horner syndrome. Horner syndrome is a triad of ptosis, meiosis, and anhidrosis. So ptosis means a drooping eyelid. Your sympathetic nerves supply some of the muscles that raise the eyelid and keep it open. So if you have Horner syndrome, there will be a partial drooping of the eyelid. Miosis is a small pupil, so the sympathetic nerves dilate the pupil. So if you lose sympathetic innervation, the pupil will become very small. That's miosis. And then anhidrosis refers to lack of sweat, which can occur on half of the face in a patient with Horner syndrome. Now, patients usually don't notice that they aren't able to sweat on half of their face, but what they will notice is that their face becomes very red whenever they're warm or hot. And that's because sweat is a major way by which we dissipate heat. So if you don't have the ability to sweat, your face will turn bright red in the setting of heat exposure. And that's how a person who has anhidrosis can present. And then two other potential complications of lung cancer are development of a Pancoast tumor and the SVC syndrome. And so let's talk about these two things now. So a Pancoast tumor is a lung carcinoma that develops at the apex or the top of one of the lungs. This is a picture here from a patient who has a right Pancoast tumor. You can see this white hazy area in the right upper lung. That is a tumor, and when lung cancers occur in this spot, we call those Pancoast tumors. These tumors usually involve an anatomical structure called the superior sulcus. This is a groove that's formed by subclavian vessels as they carry blood and nerves to and from the arms. So what this means is that when a patient has a Pancoast tumor, the arm on that side is going to become abnormal. First of all, venous drainage from the arm can be affected, so the arm can become edematous on the affected side. Patients can also develop shoulder pain on the affected side. Classically, it's pain that radiates towards the axilla or the scapula. And then nerve disruption can cause paresthesias and weakness. And so all these symptoms like edema and paresthesias and weakness and shoulder pain, all of this occurring in a patient who has a lung tumor should bring to mind the development of a Pancoast tumor. In addition to all these things here, you can also get compression of the sympathetic nerves in some cases of Pancoast tumors. And when this happens, this can lead to a Horner syndrome, just like we talked about in the last slide. Okay, let's talk about the superior vena cava syndrome, or the SVC syndrome. This syndrome develops anytime there's an obstruction of blood flow through the superior vena cava. So if the SVC becomes obstructed, then blood cannot drain from the face, and that's what leads to the symptoms of this syndrome. This can be caused by compression of the SVC by a tumor, so lung masses can do this, like non-small cell lung cancer and small cell lung cancer. This can also happen from mediastinal masses like lymphomas. And then sometimes you will see the SVC syndrome from someone who has a thrombosis in their SVC. This often happens in patients who have indwelling catheters or pacemaker wires. These things can become a nidus for thrombus formation, and if a large thrombus forms, then the SVC is unable to drain blood from the head. So the features of SVC syndrome are, first of all, facial swelling or head fullness. This is sort of a picture of what it looks like here in this man. You can see that he's got sort of a swollen face and upper neck, and if he also complained of a sensation that his head is full, this is the type of thing you can see in the SVC syndrome. And the bottom line here is that blood is just not draining from the face. That's what's causing this presentation. The arm on the affected side can also become swollen because blood can't drain from that arm into the SVC. And then sometimes the lack of blood drainage through the SVC can raise the intracranial pressure. So when this happens, you get high pressure inside the skull. So patients can develop headaches. They can even develop confusion or coma. And then it's rare, but there are cases reported of cranial arteries rupturing. And this is all because of the high pressure caused by lack of blood drainage through the SVC. The diagnosis is usually made by chest X-ray or a CT of the chest. This is an X-ray from a person with the SVC syndrome. This is not easy to recognize if you aren't a trained radiologist, so I don't think you should even try as an early med student. But this enlarged sort of white area over here represents a dilated SVC that's unable to drain blood because of some obstruction. And you will sometimes see these in actual clinical practice. More often, I've seen them from indwelling catheters, especially patients receiving chemotherapy. They have catheters to deliver chemo into their bloodstream. Those catheters often run through the SVC, and they can lead to a thrombus formation. And there are a number of different treatment options. You can anticoagulate patients who have a thrombus. Patients who have lymphoma are often given steroids because that will shrink the tumor. Chemo and radiation, sometimes on an urgent basis, are done when there are large tumors obstructing the SVC. And then finally, there are interventional radiology procedures where they insert stents into the SVC to keep it open and keep it draining blood. And then I'll finish this video by talking about metastases. First of all, I want to talk about cancers that have metastases that travel to the lungs. These are much more common than primary lung cancers. So for example, women with breast cancer or men with prostate cancer or anyone with colon or bladder cancer, these cancers commonly metastasize to the lungs, and this happens much more commonly than the occurrence of primary lung cancers. And when you have a tumor outside the lungs that has spread via metastases to the lungs, usually you see multiple foci of tumors on imaging. For example, this is a CAT scan of a patient with some form of metastatic cancer that has spread to the lungs. You can see these splotches all over all the lung fields on the left and the right side. That's what you see in metastatic cancer, because usually the metastases don't just metastasize to a single point, they spread to multiple places within the lungs. And then the last thing we'll talk about is metastases from lung cancer. So primary lung cancers have a couple of places they typically metastasize to, and you can remember these by the mnemonic Love, Effective Boneheads, and Brainiacs, LABB. The L stands for liver, so lung cancers commonly travel to the liver, and this can cause abnormal liver function tests. They also very commonly travel to the adrenal glands, although you should know this is rarely symptomatic. More often this is identified on imaging. You will see spots on the adrenal glands from lung cancer, but the patient won't have any evidence of adrenal gland dysfunction. Lung cancers love to travel to the bones, so when this happens, patients can develop bone pain, and the tumor can also disrupt bone structure and release calcium, and so patients can potentially develop hypercalcemia. And then lastly, lung cancer commonly travels to the brain, and this can cause a whole array of neurologic symptoms. And that concludes our module on lung cancer.